Assalamu alaikum. Good afternoon, everybody. Thank you for the invitation, and thanks for KGA for the great organization, and thanks for inviting me today to give this talk. It's a challenge to present NAFLD in 20 minutes, but I will do my best. So today we'll talk about NAFLD can be inevitable. I have no disclosure. So this is my outline. We'll go briefly through the definition of NAFLD versus MAFLD, and where we stand from this terminology. We'll go through the prevalence, and then stages and natural history, etiology. We'll go through the latest screening recommendation and what's the recommendation of screening. Do we need screening or not? And hopefully we'll touch base on the new treatment, the promising treatment of NAFLD. So, as we know, NAFLD is the most common cause of chronic liver disease nowadays, and the leading cause of liver transplant worldwide. Unfortunately, the majority of cases is still undiscovered. So this is the iceberg picture presenting the bottom below, the part below the level, representing the undiscovered and unreferred cases of NAFLD to the specialist. Why is that? Because NAFLD is still under-recognized disease. Referral to specialists remain low, it's less than 10%, especially from endocrinologist and primary care physician. It's a silent disease. There is lack of awareness, especially in the term of patients, no sampling diagnostic marker, and no clear screening recommendation yet. So is it NAFLD or MAFLD? So basically, there's a group of international experts, and back on 2020, they said the terminology, they proposed that the terminology should be changed to MAFLD. Why is that? Because MAFLD is metabolically associated fatty liver disease, so there is metabolic dysfunction. The second reason they proposed that MAFLD can coexist with other liver disease, like viral hepatitis, alcoholic liver disease, while NAFLD cannot. So the definition of NAFLD is hepatic steatosis plus no significant alcohol intake, which define more than 20 grams per day, no other causes of liver disease, like daily viral hepatitis, while MAFLD is hepatic steatosis plus overweight or obesity, or type 2 diabetes, or 2 out of the metabolic, out of 5 of the metabolic dysfunction, which is the visceral obesity, hypertension, pre-diabetes, low HDL, high triglyceride, hemostasis model, assessment of insulin resistant equal more than 2.5, or high CRP. So basically the studies shows the majority of cases, they have isolated MAFLD up to 80%, while combination of both MAFLD and, majority of cases shows combination of both MAFLD and NAFLD in 80% of cases, while isolated MAFLD present only in 16% of cases. Keep in mind that MAFLD associated with higher risk of fibrosis, as well as presenting on older generation, versus NAFLD, which can present in younger generation. So this is the prevalence worldwide. It's estimated around 25% prevalence of NAFLD worldwide. In our region, in Gulf, it's estimated around 30 to 35% of cases have NAFLD. This is a beautiful study from US showing the burden and the increased cases with expectation that will be almost double. In 2015, the NAFLD cases in the US was 83 million. In 2030, it will be 101 million. And in terms of NASH, there was a 16.5 cases in 2015, while in 2030 will be 27 million. Cirrhosis related to NASH in 2015 was 1.2 million. In 2030 will be 3.5 million. And that gives you like the impression we are dealing with a major health issues worldwide. So basically, what's the stages of NAFLD that we can go through, or the patient can go through? Basically, NAFLD is a broad spectrum of disease. It can range from simple steatosis, what we call stage 1, where we have only fat accumulation. Then second stage, where we have NASH, what we call it inflammation, as well as fat deposition. And then the disease will progress to fibrosis, stage 3, where we have scarring between the hepatocyte and the blood vessel. And then the stage 4, where we have the end-stage liver disease, unfortunately, and this will be irreversible, what we call it cirrhosis. This beautiful slide showing the natural history of NAFLD and NASH. Keep in mind that 40 to 60% of cases of NAFLD can progress to NASH over 4 years. 25% of NASH progress over 8 years to advanced cirrhosis, fibrosis and cirrhosis. 10%, approximately 10% of cases of cirrhosis, they will have an HCC. Keep in mind that there's a few cases, like around 20%, they can progress from NAFLD directly to advanced fibrosis or cirrhosis without going to NASH. And as well as there is rare cases of NASH cases can progress to HCC without going to cirrhosis as well. So we said always diabetes or diabetic patient always make the scenario worse. It's estimated the prevalence of NAFLD and diabetes is around 55%. Biopsy proven NASH and diabetes is around 70%. Diabetic patients have 8-fold increase in risk of progression from NASH to HCC, and as well as they have 2-fold increased risk of mortality with cirrhosis, HCC, and liver transplant. So basically, this is just theoretical. If we can apply this number on our population and our Kuwaiti population, we have 1.5 million Kuwaiti. This is the latest statistics. If we take 30% of these Kuwaiti, so we will end up with 450,000 Kuwaiti having NAFLD. 20% of them progress over 4 years. So this is number of 90,000 cases of NASH. And then over 7 to 8 years, 25% of them, they will progress to cirrhosis. So we end up with 22,000 cases of cirrhosis. 10% of these cases, this is a 2,000 case, they will end up with an HCC, liver failure, and need a liver transplant. So this is just theoretical. So the etiology underlying NAFLD is a heterogeneous complex disease involving many risk factors that play a major role and influence on the progression and the pathogenesis of NAFLD. We have environmental risk factor, ethnicity, and genetics. There's multiple genes have been studied and involved. Metabolic risk factor, diabetes, obesity, hypertension, dyslipidemia, as well as don't forget our gut microbiota, which there's many studies now coming up proving the association between gut microbiota and NAFLD. So to start with, you have a patient who have genetic predisposition to the disease based on multiple genes involvement and multiple genes mutation and polymorphism. On the other hand, you have sedentary lifestyle, high carbs intake, and high fructose, sucrose intake, giving the fact that always keep in mind there will be lipotoxicity, oxidative stress, and this can speed up the progression of the disease from fibrosis to cirrhosis, as well as increasing the risk factor for cardiovascular event in these cases. So when to refer to hepatologists, I think this is the most important aim or goal to go out from this presentation. So because we need to target high-risk population in terms of NASH-related fibrosis, we need to catch the patient earlier. Unfortunately, as I said, still the referral from endocrinologist and primary care physician is still low. It's less than 20%. So the guideline clearly said, that was published in 2022, the ACE guideline, the American Association of Clinical Endocrinology, in conjunction with ASLD, as well as the EASL, clearly said in their guideline, they recommend screening strategy, two-step screening strategy, is to do the FIB score. What we have is a FIB score. FIB score is a scoring system. You can download the calculator in your app, in your iPhone or on your Android, and you can calculate the FIB4 score. If FIB4 score is intermediate or high risk, this patient should be referred to hepatologist for further investigation and possibly liver biopsy or experimental medication. So also, this is one of the latest study that was published this month, February 2023, which said that the aim of the study is to compare two-step strategy versus one strategy is to go directly with MRE versus two-step strategy doing FIB-4 score and then MRE. They found that the diagnostic accuracy of two-step strategy is comparable to MRE. So two-step strategy should be amplified as screening method in large population. So, as I said earlier, we have many scoring systems to stratify our patient into low risk, intermediate, and high risk. The famous one, we have NAFLD fibrosis score, including age, AST, ALT, platelet, PMI, albumin, and fasting glucose or diabetes. And the other one is FIB-4 score. FIB-4 score, it's validated and studied in multiple studies, and we use it in clinical practice more than NAFLD. FIB-4 score, including age, AST, ALT, and platelet count. So when you calculate, this score should divide your patient to low risk, FIB-4 below 1.3, or intermediate, where it's the score between 1.3 to 2.67, or high risk, more than 2.67. For high-risk patient, as we said, you should be referred to specialist. So why we depend on this score? Because they have excellent and high negative predictive value. It reduces unnecessary referral by 81% and also increase the referral for cases of advanced fibrosis by fold, rather than doing invasive procedure or referring the patient early unnecessary. So I try to put and modify this algorithm for you just to see how to approach a patient, as the endocrinologist and the primary care physician, they are the frontliner always. So when you see a case suspecting to have NAFLD, do your FIB-4 score. If the score is low, so no need to refer, just advise the patient to do lifestyle modification, exercise, and dieting, and repeat the score in 1 year. If the score is high, equal more than 1.3 or intermediate, such patient should be referred to hepatologist or the specialist for further workup, most likely FibroScan or MRE. If the score is below 8 kilopascal, this is low-risk patient. We'll do lifestyle modification advice, and we might also stress in his metabolic risk factor. If FibroScan shows high reading, more than 8 kilopascal, such patient, we need more extensive investigation, and also we might try with him the experimental medication. Also, we can do plus minus liver biopsy. If we fail to get reading with FibroScan, and in case of morbid obesity, we can go with MRE or 2D shear wave elastography to get a reading for such patient. So basically, we have many methods in terms of assessing fibrosis and to know where the patient is standing rather than doing liver biopsy. We have on your left-hand side, you have FibroScan, transient elastography is widely available. It's available in all MOH hospital for free, as well as it's very easy. You can ask the patient to come for our fasting. We can do the measurement within 5 minutes. It's basically a unique technique. It can measure liver stiffness, which correlate with the liver fibrosis histologically. We have also the 2D shear wave elastography FibroScan. So 2 techniques in 1 machine. It gives you also higher accuracy. At the end, we have MRA, which is not widely available and expensive. This is beautiful algorithm or graph. I tried to put it just to make it clear to you why we are stressing on the point that we have to screen the patient and catch our patient earlier in the disease phase. So ideally we need to catch them F1, F2. So once they have F2, they have clinically significant fibrosis, and this stage increase their mortality and comorbidity. So the disease, as we said, it's a silent disease, progressive, can progress from F0 to F1, F2, F3, and then we have the end-stage liver disease. Once the patient have cirrhosis, their risk of liver-related complication will increase, as well as HCC. So basically, again, F2 equal clinically significant fibrosis, and this clinically significant fibrosis is present in around 20% of diabetes. And this Kaplan-Meier graph showing clearly that fibrosis stage predict mortality. So what treatment do we have in 2023? Again, we don't have FDA approval medication yet, but we take many strategies implementing weight loss, and we stress on the metabolic risk factor, addressing the metabolic risk factor. We know that we are in Kuwait. Our lifestyle, we are living sedentary lifestyle, not exercising, our hot weather also, and we have very nice food. So all these can lead to obesity, can lead to diabetes, circumferential obesity as well, central obesity. So the treatment focused, in my opinion, in 4 aspects. Any patient who is coming to you with NASH or fatty liver, you have to address these 4 factors. First, you have to target their obesity by lifestyle modification, exercise. Patients who have morbid obesity or obesity class 2 or 1 with risk factor, you have also to implement bariatric surgery. Number 2, target the metabolic risk factor. Always target their diabetes, make sure their diabetes is well controlled with excellent HbA1c, target their hypertension, dyslipidemia. I always notice that family physicians, they are worried or they have hesitant in giving statin to fatty liver patient or patient who have very mild elevation in liver enzymes. Statin is very safe in fatty liver or even in fibrosis related to NASH. Statin has been shown safety on such patient, and also statin-induced liver injury, it's very, very rare. It's around 0.5%. Sorry. How to go back? Yes. And then also we target the liver disease to prevent the progression of disease. Also we target the complication. So always remember that our BMI, the Asian BMI, varies from other countries' BMI or other WHO BMI. We define overweight in Asian is around 23 to 24.9. This is start of the overweight. That's you should target this BMI always when anybody presenting with fatty liver. Always remember we have modifiable risk factor and non-modifiable risk factor. We are trying to address the modifiable risk factor. Nutrition and lifestyle modification.
Dr. Mohammed, 2 minutes, please.
We have many studies and observational studies shows that low caloric diet play a major role in reversing of fatty liver. So this is the recommendation diet, and the diet on the right side, you have to avoid it. Exercise 3 times a week, aerobic and anaerobic exercise, also improve the fatty liver. There's many studies and trial. I will not go through all of these. I just want to pick one, which is one of the landmark trial by Villars and Gomez and his colleagues, that it's a prospective trial that involved almost 300 patients, biopsy-proven NASH. They enrollment these patients onto aggressive exercise, dieting, and weight loss. And the beauty of this study, where they did liver biopsy at the initial of the study and after 52 weeks, and they found that patients who had a good magnitude of weight loss, 70% have weight loss of 5% and 10% have more than 10% weight loss. And they found that 90% of patients who had 10% weight loss, they have NASH resolution. 81, they have fibrosis regression. 100% they have steatosis improvement. I will skip this. So pharmacological treatment, as I said, there's no license for pharmacological treatment. We have many emerging drugs that almost reaching now 2B and 3 phase. I will pick up one of these because of the time. This was obticolic acid, one of the nuclear receptor that's highly expressed on the liver and the small intestine. And it's the first study that shows positivity in reversing fibrosis. This study that's published in 2019. by Yunusi and his colleagues. They recruit, it's a multiple center randomized controlled trial that involved more than 2,000 cases. 900 of them, they have advanced fibrosis based on NASH. The aim of the study is to show the safety and efficacy of this drug and NASH-related fibrosis, and the primary outcome, the end point of this, the primary endpoint is to show a NASH resolution without worsening of fibrosis, or fibrosis improvement without worsening of NASH. And this is the regenerate study. They randomize the patient to placebo, 10% obticolic acid, 25 milligram obticolic acid, and the aim, as I said, fibrosis improvement by at least one stage, or NASH resolution without worsening fibrosis. And they did repeat the biopsy by the end of 18 weeks. But unfortunately, FDA, they have an issue with the liver biopsy reading in this study. So they advised the Intercept, the company, to reanalyze the biopsy. They put the criteria for the Intercept, and Intercept company, they did a reanalysis based on this criteria. Sorry. So based on this criteria, the company, they read the liver biopsy again, and
Dr. Maen, time.
10?
Time.
Okay. That's it. I will leave it here. Thank you.
Thank you very much for a very thorough and informative lecture, Dr. Maen.